Good afternoon, everyone, and welcome to MHN Talks in 10. It's our series of short, high-impact talks for FQHC leaders designed to spark ideas and actions. Thank you for joining us today. Today, we're diving into financing the future of primary care, and it's a topic that's really timely during this challenging time. And I'm really honored to welcome Louise Cohen, CEO of the Primary Care Development Corporation, or PCDC, as they call themselves. Louise heads one of the largest not-for-profit Louise heads one of the largest not-for-profit funders of community health centers, with $1.5 billion leveraged in financing to date, which is pretty astounding. PCDC funded projects have created or preserved thousands of jobs and brought investment, tech support, and training to primary care practices. Equally as impressive is their advocacy work. PCDC is leading a coalition aiming to have 12 to 15% of every healthcare dollar coming into primary care. And it's really a movement that's taking hold. Under her leadership, PCDC is also leading the way in financing innovative programs and services to support community health centers, and Louise will share some exciting examples of this work. Louise is really a visionary leader with deep expertise in both public health and other health systems work. She's worked with the New York Department of Health and Public Health Solutions. So we're thrilled to have her. Let's get started. Louise will share more details about PCDC's work, and then we'll open it up for a brief Q&A, and I'll turn it over to you, Louise.
Great, thanks, Cheryl. We really appreciate the work of the Medical Home Network. Let me share my screen, and hopefully you can see that. As Cheryl said, PCDC is a community development financial institution dedicated to health equity. And we have been very active in working with federally qualified health centers across the country, but also with behavioral health safety net hospitals. And you can see that we've been able to, with our strong partners, really, we think, make a big difference in the primary care ecosystem. But you all know, I'm pretty sure, that that we have a problem, that the healthcare system is not producing good health for many people or their communities. And we know that there are extraordinary disparities in care and outcomes. So PCDC's own research shows that in New York City, the lowest income neighborhoods have almost 5 times fewer primary care providers than the higher income neighborhoods. And they have the highest all-cause mortality and preventable hospitalization rates. And so you can see here on the slide some of the other data that I'm sure that all of you actually know and probably talk about on a regular basis. So what's the solution? Well, we think that rebalancing the healthcare system is actually the most important solution and a systems approach to what needs to happen. So we know that adults who have a PCP have almost a third lower healthcare costs and about 20% lower chances of dying prematurely. We know that the US could save almost $70 billion per year if everyone used a PCP and had a PCP. That we know that every $1 increase in primary care spending produces $13 in savings. And that we know that even 10 more primary care providers for every 10,000 people in the US is associated with fewer preventable hospitalizations. And so we believe that there's a lot of ways in which one could do this. But what we know is that most people think, there was a recent study done, that most people think that primary care gets about 50 cents of the healthcare dollar, and that about 60% of people's healthcare needs are addressed by primary care. But it actually turns out that it's only about 5 to 7 cents on the healthcare dollar that goes to primary care. And so we know that that's also dropping. So we believe that there are ways in which we could rebalance the healthcare system, spend more on primary care, reduce our costs, have better outcomes. And we can do that in a variety of different ways. Certainly, we could increase reimbursement and value-based payments to primary care. We can create and enhance teams to increase the time spent with patients and upgrade technology. We could support patient care with things like remote blood pressure, diabetes monitoring. We can talk about social drivers of health. We can talk about home visiting, especially doctor visits, particularly for older adults. We could run patient-centered programs like group visits, support early childhood literacy and nutrition. In short, many of the things that federally qualified health centers actually do provide to their patients, but are not significantly resourced so that everyone in the system gets this. And we believe that investing in all of these things, you can see here sort of some of those categories, that we really think that this would make a huge difference, both for individuals, for health outcomes, for communities, and for cost. In New York State, PCDC is spearheading a bill to do just that, essentially to ask every insurer to tell us how much they're spending on primary care today. And if they are not spending 12 and a half cents on the dollar on primary care, that they need to, over time, 1% year over year, increase their primary care spend. And they should make this information publicly available. And what this means is that we think that that will begin to drive funding into the primary care system so that we'll have a more robust workforce, so that we will have more preventive care, so that we will reduce cost and we will make people healthier. This is really a fundamental approach to making communities healthier. And this isn't just something that we're doing in New York, right? This is something that's happening across the country. So PCDC is spearheading a group called the Primary Care Investment Network. It's made up of state officials and advocates from about 25 states, actually, that who are all pursuing policy in some form or fashion to do the same thing that we're doing in New York. And it's all across the country. It's Colorado, Connecticut, Delaware, Oregon, Washington, a variety of places in Rhode Island, in Oklahoma, and in Arkansas is the latest state that passed just recently passed legislation to create the Arkansas Primary Care Payment Improvement Working Group with very strong bipartisan support. So we believe that this is the broad strokes about how do you move the system, how do you rebalance it so that overall we're really spending money in the right place to get the outcomes that we want. And finally, let me just say that partnering between organizations like PCDC and the Medical Home Network is what is going to make the difference as we both work to support federally qualified health centers, primary care, and the communities and the people that we all serve. So if you want to get in touch with us, this is the best way to do it. I'm really glad to be with you here today and glad to answer any questions or share more thoughts. So I'm going to stop sharing and put Cheryl back up on the screen, and we can chat a little bit.
Wow. Thank you for those thoughts. I love the word movement, right? It's, really aspirational, but really needed. So PCDC is really working to drive impact and bring resources and strengthen primary care. What I'd love to do now is take a few minutes for a little bit of conversation and Q&A. If you have any questions, please feel free to drop them in the chat. But let me just see what we have here, and I will kick us off. Louise, maybe I'm going to start with PCDC is advocating for 12 to 15% of healthcare dollars to flow to primary care. That's a really bold goal, and I love it. From your experience, what are the biggest policy or market barriers to reaching that target, and how can FQs be a part of the solution?
So I think federally qualified health centers are in fact part of the solution. They actually, have a required federal rate that they get paid, which is a great step in the right direction. It is just simply not enough to pay for the services that they provide, especially as salaries have gone up and costs have gone up across the board. What I would say is that in general, I think that we want to begin to sort of have everyone understand that federally qualified health centers are really anchor institutions in communities, just like hospitals and just like some of the other healthcare organizations. And they provide good jobs. They provide a great deal of tax revenue into their communities, they may be not for profit, but they're paying sales tax, and they're paying they're paying income tax. The people who work there are paying income taxes. There's a whole aggregated economic benefit. But the policy issue that folks come across for me are two things. One of them is there's a concern that we might be paying primary care doctors more, and that's really about what this is about. And what I would say is, yes, we actually do want to pay primary care doctors more because they're the lowest paid physicians outside of public health physicians and behavioral health folks. The fact of the matter is they get paid qualitatively less than specialists. And yet they are responsible for a whole person care. And so we think that that does have to change. But we actually think that there are a number of other things that have to be changed as well. I think a lot of times people tend to think about, well, there's a policy solution or a kind of, we should all move to one particular reimbursement structure. What we're saying is there have to be a whole variety of things where the reimbursement and the incentive payments all align, certainly best across payers in order to sort of get to where we want to be. But what we also know is that this isn't going to happen on a system level until we require it. And so there's states that have required, for example, Rhode Island's the one that's done it the longest. They required 1% increase year over year to get to 14 cents on the dollar. They did that successfully. They now have more primary care providers in their state, and costs went down. So while it's a small state, there are other states that have done this as well and have seen similar kinds of improvements. So we know that a broad idea of like spend money in a variety of different things, but overall the spend has to increase, is actually a good mechanism for getting to where we want to be.
And how perfect was that? One of the questions that was presented was about Rhode Island and the experience of increasing primary care spend versus the impact of hospital rate caps. So
yeah, I mean, I'm not sure that I could say one or the other, but I would say that there has to be a concern. It has to be an effort that goes around, right? People often think, well, we're rebalancing the healthcare system. That means you're going to take a bunch of money away from hospitals. And my sense is we actually want hospitals to stop spending their money in the wrong place. We should stop seeing people in the emergency room who have preventable illnesses. If you have diabetes and you need your toes amputated, yes, we actually need a hospital in order to do that. That's true, but we should never get to that point. And never getting to that point means enhancing the primary care system. And that's where we're going to see the rebalancing.
Excellent. Okay, I'm going to go for one question. We're running a little long, but I want to get this out there. PCDC has done some really excellent work in funding innovation. Can you just share a couple examples of what you've done?
Well, first of all, let me say that it's our federally qualified health center partners that are really the innovators, and we're providing the capital and the technical assistance to help them get there. So one health center that we financed actually recognized that childcare was a major issue for their staff and for the community. So they actually built a childcare center with our financing. And now they have a childcare center for their community and for their staff. And they also have, because there's now rent coming from that to them, so they now have also a financial sustainability. So that was a great project. Another one that we did was a lot of integration of behavioral health and primary care. Sometimes it's a primary care practice and FQ acquiring a behavioral health center, and sometimes it's the other way around, but it's those two things together, which we think is really important. And then I would say two other things. We financed, for example, a foster care campus in a city where that was then enabled a primary care center run by an FQHC to come in and provide services to the children in that center and their families. And then finally, we were able to finance a really innovative program where that included housing and primary care for women who were either coming out of incarceration or psychiatric facilities where they could be with their families, which is very unusual. Most of the time, these halfway houses or other kinds of residential treatment programs just are for the person and not for their families. But we know that women, many women, most women have children who then need to, family reunification is really a critical component of that, and primary care is really essential in that. So those are just some examples of where we think that folks out there in the community are doing terrific work, and we're really proud to be financing that. And our innovation comes from the creative ways in which we finance these programs to ensure the long-term financial sustainability and health of the organizations that we finance.
Oops. Yeah, that's terrific. I love those projects. The childcare is so amazing. Hadn't heard about that before you shared it. Um, Maybe for our last question, can you just share the value that PCDC brings to support primary care capacity building and financing? You provide so much subject matter expertise and knowledge that and crosswalk between the lenders and the health centers. Can you just surface that a little bit more for all of our attendees?
So yeah, I think that health centers, you know, often come to a point where they have capacity problems, right? They even, they've just the health center might have been built a while ago, and what we've learned is we have longitudinal relationships with our health center partners. So, for example, way back in the 1990s, we financed a health center for LGBTQ folks in New York City, and we helped them become a federally qualified health center. So that was technical assistance. We helped them build their health center. And then 20 years later, they needed a roof replacement. So we helped them build that. And now we're helping them build two other sites in New York City. So the point is that we're there to help provide solutions to problems that folks face. And especially for folks who can't get a bank loan. There are some federally qualified health centers that are big enterprises and really can get bank loans and can manage that. But what we've learned is that a community lender like ourselves, first of all, we know FQHC's business. So we understand the ups and downs. We understand the payment mechanisms, the reimbursement. We don't treat you like, like you are just some other kind of business. We actually know your business. And we will come up with creative ways to solve a funding problem. Sometimes we've said to people, you know what, this project is too big for you right now financially. Let's break it up into 3 pieces. And then they actually got there and did all 3 pieces and were successful. So our goal is to make FQHCs be successful by using the power of community development. And that, I think, is a marriage that is really, really important, because we all know that our health centers won't be around unless they're financially sustainable. But their work ultimately is to help people be healthier in the community. So we provide some of that specialized knowledge to support the mission of the health centers, which is really our mission too. And frankly, I know it's the Medical Home Network's mission. So this is like a great opportunity to, for a lot of different pieces to come together to make sure that our health centers are as strong as they can possibly be and grow, which we think is really important.
Indeed, I couldn't agree more. Well, Louise, thank you again for joining us and sharing your insights, and a really big thank you to PCDC for all the amazing work your organization does. We hope today's Talks in 10 gives everybody something to think about, and we look forward to seeing you next time. Have a
Well,
great.
thank you so much. And you all take care.
Thank you very much. Thank you, everyone.